Now. Thank you so much for the introduction, and thank you everybody for attending this short session. It's a pleasure to talk to you about evaluation capacity building in an interorganizational perspective, and I'm so happy to see both Isabel and Brad Cushions. Brad visited me last year in Denmark, and it was a pleasure meeting him. I'm a PhD student at the Aalborg University. My name is Charlotte Laubæk, and my supervisors are Professor Anne-Katrine Krogstrup, who's a professor in evaluation, and Professor Janne Seemann, who's a professor in sociology. I am a member of the research group Capacity Building in Evaluation, and we focus on research activities in meaningful capacity building, innovative and development processes in private and public sectors, as well as new evaluation models. I'm also, as Isabel said, an evaluator and a strategic consultant working in municipalities doing both collaborative and participatory evaluations. You can see me here in action. I'll start by giving you a brief introduction to the empirical field. For decades, public institutions have struggled with fragmented structures, silo thinking, and increasing in complexity, for instance, in the healthcare sector. It is well known that the demographic development, rising costs, lack of employees, and collaborations between the different sectors, in this case, hospitals, municipalities, and general practitioners, is the cause of poor quality. Lots of research has been done on this. At the moment, new ways to both evaluate and solve the complex problems in the healthcare systems are needed. I'm taking my point of departure in my research in the quality improvement work in the healthcare sector in Denmark. As you can see, it's built by regions, private clinicals owned by general practitioners, the pre-hospital and emergency response units, and the municipalities. There is a shift in the paradigm of the quality improvement work in Denmark. It's moving from using accreditation, external evaluation and control with a focus inclusively on quality of care in the hospital sector, moving to a strong focus on learning and stakeholder involvement in local improvement work and evaluation activities across the healthcare systems. Looking into this research area, I'm using a quality improvement model as an example of a quality improvement method that has a very strong element of evaluation, which is typical for quality improvement models. In this case, I'm looking into the model of improvement that uses the plan, do, study, act circle, as you can see in this picture. Using these methods, stakeholders, in this case, clinicals, nurses, doctors, general practitioners, are involved in doing a change of theory. They're defining what are we trying to accomplish, how will we know what a change is an improvement, what change can we make that will result in improvement. Having defined what the problem is and what the improvement initiatives can be, they start using the plan, do, study, act circle. And there are 4 phases in this. First, they plan their improvement activities, then they test them in practice, in the clinical practice, in the everyday working life. Then they study, and this is where we have the evaluation element. They study whether or not it works, looking into both performances, processes, and effects. And in the end, they're using the evaluation findings to adjust their change of theory. Using the plan, do, study, act circle is not a question of just doing one evaluation. You use it in small scale tests, and then you escalate the test, doing a series of evaluations. In the end, testing your improvement initiatives in a large scale, and in the end, using the evaluation findings to decide whether or not to continue the improvement initiative or to stop it. In the beginning of my PhD project, I've done a literature review that shows that the core elements in the PDSA circle that create learning are systematic, iterative, and improvement-oriented evaluations, collaborative and employee involvement processes. These two elements are core elements, but research shows at the same time that these elements are most often absent in practice. Lots of research shows that due to the lack of these two elements, the PDSA cycle has only to a poor extent learning and improvement outcomes. Based on this, I've made a theory-driven program theory. Theory is that quality improvement methods do not enhance learning or improve quality due to the lack of evaluation and stakeholder involvement. We know from literature that engaging stakeholders and managers in collaborative evaluation activity builds indirect evaluation capacity. Building indirect evaluation capacity can result in learning and capacity to do evaluation findings for decision-making and improvement at different levels within and across organizations. We know that from research, but we do not know how it works when we look across organizations. Which leads me to these research questions. What interventions, mechanisms, and contextual factors can help build indirect capacity to do and use evaluations in such a way that evaluation capacity building and learning is enhanced in an interorganizational context? For you that are not evaluation capacity building nerds, as Isabel and Brad are, it would be proper to describe and define what is evaluation capacity. Well, individual evaluation capacity reverts to knowledge, skills, and attitudes required to conduct evaluations successfully and or to use them toward program improvement, learning, and decision-making. This capacity can be built by doing learning by doing activities. When you do that, it is referred to as indirect evaluation capacity. Organizational evaluation capacity is a context-dependent intentional action system of guided processes and practices for bringing about and sustaining a state of affairs in which quality program evaluation and its appropriate uses are ordinary and ongoing practices within and or between one or more organizations. I'm looking into this element of uses and ongoing practices within and between one and more organizations. And this adds a new element to the evaluation capacity literature and research, I hope. But why is it relevant to look into interorganizational evaluation capacity building? Well, as I showed in the beginning of this small lecture, there are several complex problems in the healthcare sectors as well as in the public sector. Solutions to these complex problems are often transcend the capacities of individual organizations and sectors to deal with them adequately. And research suggests that public organizations need to use multi-stakeholder approaches. Organizations that collaborate create better solutions than what they can achieve on their own. Building on this, I'm using a theoretical framework with 3 theoretical components. I'm using theory on evaluation capacity building. I'm using theory on collaborative approaches to evaluation, as we know from research that using collaborative approaches to evaluation can help building evaluation capacity. And as a third element, I'm using theory on learning and interorganizational learning. These are the elements of my PhD project. I've done a literature review looking into evaluation and quality improvement in interorganizational healthcare system. Not much is known at the moment about this. I've made a state-of-the-art review looking into the connections between evaluation capacity building and learning, with a strong focus on interorganizational learning. I'm doing empirical studies on activities, mechanisms, and contextual factors that can help build indirect evaluation capacity in the interorganizational context. And finally, I'm looking into connections between interorganizational evaluation capacity at a micro level, at the stakeholder level, and at the level in the organizations where decisions are being made by managers. My research design, just briefly talking you through that, it's a two-case qualitative case study where I'm looking into different evaluation activities embedded in two large quality improvement projects. And in a moment, I will introduce you to these projects and cases. I'm doing a comparative analysis, and I'm building on critical realism and program theory. As you can see, the two cases are embedded in the healthcare system, and I'm also looking into the connections between the project groups, the case 1 and 2, and the connections between these project groups and the managers at the organizational level. The two cases are project groups established across the healthcare sectors. In the one case, they're looking into prevention of hospital admissions, especially looking into how you can treat and care for elderly and chronically sick patients in their homes instead of admitting them to the hospitals. In the second case, the project group is working on improvement care for patients with dementia. This group of patients has a 50% higher rate of being admitted to hospitals, but the lack of quality and care for these patients is very high. In each group, there are around 30 stakeholders from all different sectors in the healthcare system: nurses, general practitioners, doctors, and social healthcare workers. They're representing around 30 different organizations in each project groups. And what are they doing in these quality improvement project groups? Well, they're using traditional quality improvement policies, practices, and procedures. For instance, the PDSA template and other tools used to do evaluation. They're also attending workshops on evaluation and the use of the PDSA circle and analyzing and collecting data. They meet at least 10 meetings where evaluators are conducting evaluation using the PDSA circle. And here comes to the difference between the two cases. In case 1, the evaluators are conducting the evaluations, but in case 2, the evaluators are facilitating collaborative evaluations using the PDSA circle to do learning by doing activities where the stakeholders are doing the evaluations. And added on, in case 2, they're doing 10 collaborative interorganizational program evaluations where the stakeholders are doing the evaluations facilitated by the evaluators. So that's the main difference between the two cases. At the moment, I'm analyzing my data, and I have quite a lot of data from interviews, observations, and documents, and I'll share a bit of my preliminary findings with you. I'm quite humbled to say that I haven't finished my work yet, and I'm looking forward to discussing it with both Isabel and Brad while I'm here in Canada. So these are just preliminary findings. In case 1, you see, by the way, you see here on the right side, you see the project groups, and you see the difference in the activities they're attending. In case 1, where they're working on prevention of hospital admissions, I observed that their evaluation processes can be analyzed as passive learning processes. They're passing on information to one another, not engaging in dialogue or reflection, or not doing what we could define as evaluation. In case 2, The processes can be analyzed as interactive and interorganizational learning processes. We can observe, and when they reflect upon what they're doing, they define it as dialogue, reflection, and learning-oriented negotiation concerning both values, quality criteria, beliefs, and knowledge. The outcome of these processes are quite different as well. Looking into what evidence can be found as to capacity to do evaluation and capacity to use evaluation, in case one, the stakeholders are able to collect data and in some ways able to collaborate in analyzing data, but there are no evidence whatever of capacity to do evaluation and not evidence of evaluative thinking. In case two, it's quite different. We see that the project group develops theories of change, they do program evaluation, they collect data, reflect, analyze, and do evaluations of both processes, performances, and effects. They're able to order relevant data and collect data, and as well developing, using, and adjusting their own evaluation tools and templates. As concerning to the capacity to use evaluation, we find evidence of instrumental use, and findings are used to orient program evaluation. Also, signs of evaluative thinking is found in case two. Looking at the learning outcomes, in case one, we find that knowledge of existing procedures that have not been implemented is the most serious evaluation finding. It doesn't bring us any closer to solving problems or being even more alert to what could be problems in the future. We see individual and organizational learning, but on this level, you could call it bad learning because the narrative is more us against them. And this does not enhance interorganizational relationships. In case two, the project group is able to uncover and define new common problems as a starting point for finding, testing, integrating, and implementing joint solutions in both individual organizations and across sectors and organizations. They're able to set and reach common goals. And we see individual, organizational, and interorganizational learning. You could call it a narrative, as we are all part of a connected whole. This adds to the enhancement of interpersonal relations that seems to be quite important in the interorganizational context. As for you who are almost falling asleep at the moment, I'm glad that you're still here. Looking into the context when we're trying to build evaluation capacity, it differs, as far as I can see at the moment, from what happens in an organizational context. I've shown you here a picture of the battlefield, and what this is what you can experience when you enter the room when stakeholders are doing interorganizational evaluations, at least in the beginning. Each organization has its own evaluation and learning culture. There are multiple professional strategies as well as professional and financial incentives at stake. There are power struggles between the different stakeholders and organizations, and there are also prejudice and myth about the other organizations and sector. I don't know how it is in Canada, but in Denmark, there's also a severe lack of interorganizational data, which adds to the conflicts in this room. So, what can I say about what works for whom and why at the moment when we're building indirect evaluation capacity in an interorganizational context? Well, as far as I can see at the moment, collaborative approaches to evaluation and interactive learning processes enhances the possibilities of building capacity in this interorganizational context, as well as time. It takes quite a lot of time building this capacity and building relationships as well. Looking into the contextual factors that can enhance the ability of building evaluation capacity. Access to transparent data, which reflects both interorganizational practices, performances, processes, and effects, is quite important. And certainly a learning environment characterized by learning-oriented evaluation inquiry is very important, as well as evaluators facilitating capacity building initiatives and learning by doing activities. Looking into the mechanisms that can trigger building evaluation capacity, the feeling of trust and safety in the environment, as well as meaning and motivation, is important for building capacity to do evaluation. As far as the capacity to use evaluation, engagement is quite relevant, but also mandate and influence within the group, organization, and across organizations seems to have great influence, whether as it's possible to use the evaluation findings. That was all that I wanted to tell you, and thank you so much for your attention. Feel free to reach out after this short lecture. You can find my email addresses here, and I will be happy to hear from you.